being a specialist for the last 9 years. Um, the scope of job as a pediatric neurologist um, now involves looking after patients with epilepsy mainly and neuromuscular conditions, and I also look after the cerebral palsy clinic and disabilities. I started looking after the Palliative clinic in the past 1 year or 1.5 years with you and Dr. Ku. So the scope has definitely changed from before I started training in neurology, whereby the concept of palliation was suitable for certain people but not truly accepted by the larger population of doctors. In this field, we find that there are a number of patients who either not able to voice their opinions for the demands of care, where they could tell us exactly what they want for their child, or the parents need, the family needs towards looking after this patient. So when I joined the clinic, I found that was elevated. You know, the opportunities were given to the parent to discuss with us exactly what they wanted for their child, and the avenues were explored, how they wanted the home to be, who the family members that will look after and provide care for the child, how they come to get medical support, medication, transportation to hospital. So it just does not mean palliative care does not mean the end of life, but looking after the child throughout the child's life in a comforting and supporting way. So for me, that was it gave us a lot of opportunity, or gave me a lot of comfort, that despite me not being able to give them a medication to cure them, but at least it gave me the opportunity to provide them with avenues that they could use to improve the child's care at the end of life. So it does not mean that it's the child's going to pass away in the next day or a month. It can be a number of years, and we would just support them throughout that journey, and make sure that all the complications, all the issues that we can settle or we can help the family with, and provide better care for the child during this period is taken care of. In palliative care clinic, we look to the other needs of the patient. I think that's commonly forgotten in an active treatment clinic, like when the patient comes in, and you know, you just need to prescribe the medication, make sure that the seizure control is there, the disabilities are taken care of, the acute issues like flu, fever, constipation are managed, and the patient just comes in and goes out. Whereas in the palliative care, because you know that you're not actively treating, you're not giving a medication, but you are basically looking at other aspects of care, then we end up we actually do very well, because we go through the family dynamics, the living, the child's condition at the current stage of disorder or disease, and how else we can help the child to manage a good quality of life. So sleep is looked into, constipation is actively looked into, how they manage the secretion, their nutrition, and feeding, and eventually even simple things like how do they get from point A to point B, how the family manages the child. Sometimes we even do provide scope for employment, respite care, which is a very big thing in looking after a child, because these guardians need some holiday away from looking after these children. So I think that's very important. And one of the main things that I need to highlight is the management of pain. I think pain is very often overlooked in our clinics, and in palliative care, that is of high importance. We do um, we do provide a lot of support for pain medication or pain management for these patients. I think it was, for me, it is a natural progress of how I've been trained or what I have seen in my career as a doctor. So initially it is very exciting to find a diagnosis and treat the acute stage of any illness. But towards, as you go along with the patient, you see that their needs or the dynamics in the family and the patient also changes. And now that I've moved into more of a, my main interest is in disability, neuromuscular care, and looking after these children, I felt that it was a natural progress to look at things that I cannot treat. So if it is something that I cannot manage, and there's something that I cannot offer them, then this was a good avenue to provide them with the maximum comfort. So it does not mean that I stop looking after them, but I follow them in a different journey to give them a fairly good chance at life. The joys of life, like watching TV. I give them a proper seat. They are able to go to the park because we have provided them with a proper wheelchair. They are able to go on a holiday because we have provided them the avenues to mobilize. The family is able to think about taking the child out rather than keeping them cooped up in a room. So these are just simple things that in a very busy, active clinic, we always overlook. We don't look into that. And definitely pain. So sometimes these children, because they're not able to express pain, we forget, or we do not look at them or treat pain with the seriousness that it requires. Yeah. So I think our lives are peppered with these incidences. Sometimes the child themselves grow on you, and sometimes it's the way the family interacts with you, or they become part of your family, or you become part of their family, and that's when you really feel the loss. But over the years, I think, not to say we grow immune, but we kind of encompass all that into our experience bubble, and that gives us a good guide of where we pitch things with different patients and different people. And sometimes it makes us understand that everything is just not at the face value. Sometimes parents are unable to express themselves, or they are unable to tell the true surroundings of the patient or their abilities to care for these children. And when with the vast communication that happens with these children, sometimes we do see that it just improves with time. The first experience that I had as doctor was when I was a house officer working in PPUM, now known as University Malaya Medical Center, and I was tasked with looking after this complex a child with multiple abnormalities, and had a ventilation on board. And this child grew on us because, as the house officer, I was tasked with giving medications, putting in the Ral's tube, taking blood daily, and managing this child. And as a team, my consultant had discussed with the parents on multiple levels, and when the child actually deteriorated and was not doing too well, the parents actually requested, or the team actually suggested to the parents, that we could bring the ventilator all the way to the car and let the patient be extubated in the car, where the father thought that he didn't want the child to pass away in out of home setting. So true enough, the child could not withstand even a few minutes of being extubated, but the child demised at the inside the parents' car outside the hospital. But that experience, coming down, bringing the child down with a ventilator, the amount of coordination between the team and giving the parents what they wanted. So there was a photo session. There was parents had taken footprints of the child's feet, and they had made like a small collage with some of the hair from the child's scalp. And I think that keepsake for the patient, for the parent themselves, I think healed a lot of wounds. So that was my first experience looking after a complex child with these kind of issues. And over the years, we've definitely seen, invariably, um, um, week after week, or sometimes even month after month, multiple deaths, and sometimes we have to withdraw care, and it has never been easy, but it always gives us an opportunity to improve ourselves by looking to other avenues, what we can manage and what we cannot manage, and always keeping that communication line open between parents and ourselves as a team. Yeah, so sometimes I feel that every death is a big impact to me. Okay, though my late mother would beg to differ. She always thinks that I'm immune to death, but I think death is very beautiful in its own way. It is whatever for me, it's mostly children passing away. So whatever the child brought to the child's self and the family is a big gift on its own. So some parents, though the disease or the disease burden is a lot, they still value that their family came around to them, somebody came to help them, they were able to get time off work, they could reevaluate a lot of relationship goals, they could reevaluate what was important in their lives. So a disease, or a chronic disease, or a disease or death, actually, if looked positively, is actually quite brings about a lot of awareness. Yes, definitely. It's a very new concept. It's something that not not many of us, or not many doctors are aware of or can accept, compared to adult palliation. When a child is on the route to passing away much earlier than their parents, in our culture, I think it's very difficult. I suppose in any culture it's difficult, but I find that our parents over time, with good communication, good, I think once the communication is clear, or the needs of care has been explained to them, parents today are better equipped to make the decision. So we don't see what happened maybe 10 years ago. When you say palliation, everybody gives you this horror look on the face, like, what happened to my child, like, now what you want to do? Are you going to pull off the tube and let my child just pass away without anything? Or like, we never looked after anything else. So I think that concept has changed because of the way we communicate our goals of treatment, and we listen to what they want. So because we do that communication has improved. I don't see though the concept being new, I don't see parents not being able to accept palliative goals of treatment as any different as you would give medication to the patient. So I am very happy that yourself, Dr. Lee, you have actually started up palliative care in this setting, in our hospital setting, because sometimes as clinicians we forget, like I said, we forget the core or fundamental other goals that need to be sorted out, and palliative care being once it's decided or the team has decided that they are not able to provide realistic chances at treatment, then when we decide to put the patient into a palliative pathway, this whole group of people come together to make it happen. So obviously, I think the main limiting factor is always going to be budget. But other than that, I think having a big a, a goal orientated team to manage secretions, pain, comfort care, ambulation and mobility, and also looking at the psychosocial aspects for the parents and mental health care for the patients, because some patients are aware of their disease, especially our oncology patients or our my neuromuscular patients, they are aware of the disease, so the disease process and the disease. So once when we give them that opportunity and we are able to provide them with this support, I think that will be when we have truly achieved a good standard of care or setting goal setting for our palliative care patients. I think everyone should realize that palliative care is not the end of life. It is palliative care is not the end of life. It's a way that we can provide another avenue at treatment options for our patients, so that the journey beyond is acceptable, or the journey beyond is meaningful to the child and to the family that is looking after them.